I'm absolutely delighted to see so many people in the room all here to discuss a true passion of mine and have had for several years in trying to improve the ward round process, particularly with the MDT in mind. So I'm the clinical lead for acute medicine, and as I said to two ladies earlier, I'm a geriatrician in disguise. I trained in geriatrics, so for me, MDT working is absolutely key. And the ward rounds for me have always been that fundamental process where the MDT and the patient come together, as Nicholas was saying. And actually, fundamentally, the patient is the most important player and participant, and should be an active participant in ward rounds. So I've been working on simulation training, and it's the kind of simulation where you actually throw the dummy and the high technology out the room, and actually you don't need a simulation suite. So I'm delighted to be here to talk to you about how that's been working. We know in 7-day services and current services as they are that although most consultant job plans allow for 2 ward rounds a week, the majority of ward rounds on a day-to-day basis are actually led by trainees. And so when we're thinking about ward rounds, I think it's really important to think about how trainees are trained to perform that duty. And learning by osmosis from some significant variation, as we know in consultant practice, may not be the best method. You've probably seen the document back from 2012, which was an RCP-RCN document looking at the principles of best practice of ward rounds, and it covered things like checklists and absolute importance of having nurses on your ward rounds. But for me, it really wasn't prescriptive in how I could translate that into my practice. So the drivers really for me thinking about ward rounds and change, actually my medical director said to me back in 2011, here's a checklist, I want you to bring it in, and I said it's impossible. People aren't going to just accept a checklist unless they understand why it's needed. And also I was concerned that the checklist would be a tick point exercise and actually bear no relation to change in practice or culture. And we knew from various incidents, complaints, when you look back on them, they trace back to failures that had occurred during the ward round, either from a communication point of view or failures in management or communication of plans between members of staff. So there were local drivers. So what we did at the beginning is we started looking at the trainees and asking them that question, well, what training have you had in ward rounds, given that this is something you're going to do day in, day out? And only 15% of the trainees that we surveyed had had any form of training in their undergraduate or postgraduate careers, albeit they varied from F1 up to specialist registrar. And about half of them rated themselves in a 5-point Likert scale as anywhere being confident leading around. And these are the people that are then going to see the patients. And really worryingly, from patient safety aspect, really key things that influence patient safety, like checking a patient's allergy status, reviewing resuscitation status and sealing of care decisions, was done pretty poorly. I think you can see from the figures there. We also did a patient survey. We went round to speak to patients after the ward rounds had occurred in the morning, and we surveyed 100 of our medical inpatients. And although this is reasonably good, this was before the Hello, My Name Is campaign that Kate Granger launched, 79% said that the doctors had introduced themselves, but worryingly, still 20% had actually walked to a patient and not introduced themselves. But they certainly didn't introduce the team around them. As a consultant leading a ward round, if I have a team of juniors with me and I then go away to clinic or something else in the afternoon, I want my patient to know who my core trainee is, so that when he comes back to speak to the patient, you're not starting from a blank sheet again. We know from complaints as well that patients aren't given information around their discharge process. So in these cases, 58% weren't given any idea about their discharge plans. So how can you plan together with the patient about going home? And you wonder why there's flow and capacity issues in hospitals. If the patients aren't on board from the beginning about what's going to happen to them when they're likely to get out of hospital, because let's face it, that's their number one aim normally, we're not going to win. And only 61% felt they had any clear understanding of what the plan was for their care. And I felt that this was really powerful for me. Really simple things like I like the simple name and rank chest labels. So one of the first things we did was change our ID badges, because so many have ID badges that you wear around your waist, which is rather odd to be looking at someone's groin to see what their name is, in tiny writing. So we did some 3-foot, you looked at your ID badge from 3 foot, could a patient still read it? So all of our staff now at SASH have badges with very clear denominations: doctor, nurse, matron. no real hierarchy apart from a consultant, and they're in very large fonts so that actually you can read them. Really simple things. Patients said that new members of the team should be introduced, and where consultants rotate, this should be explained. So often in acute medicine on my ward, I'll do a ward round Monday to Wednesday, and then a different consultant will do Thursday, Friday. And it's important for patients to understand that that changes, and you have to have an awareness of who the person is responsible for your care. Not too sure of what is happening, but didn't want to ask. And for me, that's key, because our job is to empower our patients and our staff to speak up during ward rounds. That's the only way they'll get better. So we know simulation is very well established practice for teaching things like team working and human factors, but so much of it has been looking at acutely unwell and deteriorating patients with the, the dummies on the trolley and all the fancy machinery that I'm kind of scared of and keep away from. But we know that there was some evidence right at the beginning that simulated ward environments are quite well validated for assessing ward-based processes in surgery, but there wasn't much experience in medicine. So this is where we introduced. So we've developed at SASH something called the Quality Ward Round Programme, which started basically as a 3-hour training session where we used simulated ward patients, and we actually have an actress who's highly experienced and sits on many patient groups to present the patient's perspective of the ward round. We have scenarios, really straightforward ones, and they're not testing the doctors or whoever the participants' clinical knowledge. They're much more around the process and the structure of ward rounds. So the learners, whoever it is, doctors, nurses, pharmacists, etc., have the opportunity either to be a leader on the ward round, which might be the first time they've ever had to lead a team seeing a patient, or they're active participants in being the observers, and they have a peer-to-peer debrief, so they're the ones that feed back their observations. And one of the things we focus on primarily is about the patient experience, but we look at key things that affect safety and quality on ward rounds, so your VTE prophylaxis, your drug chart reviews. Every day I review my own drug chart, and every day I will find an error, probably 1 in 3 patients. And in the absence of having wonderful pharmacists on my ward round, which is one of my key objectives and has been for some time, it's absolutely paramount that those key safety things are being done. So the sim training is completely low technology. You don't need a sim lab, you just need a room and you need some willing volunteers to be your facilitators. It doesn't cost much only in terms of time. And you can really do it for up to about 20 students, but it's much better and more meaningful in smaller groups. So we tend to have groups of 5 or 6. We use near-peer observation because I think that's really powerful, and we've introduced having foundation doctors that have done the training in their induction to then come and train for the rest of the year, and we see their practice improving, and then their near-peer delivery to the new doctors coming in is really powerful, rather than an old fart like me telling them how to do things. And the patient feedback is absolutely vital. So the actress, or the actors that we have from a specific medical actors group, if you like, based in Brighton, are absolutely vital in providing that feedback to the people taking part. So just scenario examples, really simple. It would be something like a 42-year-old who's come in with an acute asthma, and we throw them into it. We send 6 people in, we say, you're leading, in you go. And we all observe, and they're absolutely terrified, but we try and make it as, we say, there's a pressure, just keep going. And the first thing you see is that they have no structure. They go completely circular. They talk to the patient, then they turn away, they talk to someone else, there's whispering at the back. And so after the first scenario, there's this key learning that structures what you need actually to get things done on the ward round. And we focus on the pre-round review, the round itself, and then the post-round debrief and handover. The second case, we tend to introduce the checklist just as an aid memoir to demonstrate to them all the things they have to remember during the ward round. And it focuses on things like patient safety, as I'll come to in an example. And then in the third scenario, once they've got the idea that you need clear roles and responsibilities, we've introduced the idea that a checklist might be one means of helping them remember to get everything done, is we introduce complexity. So we have an older patient with complex needs, and as we've all seen on some ward rounds, where perhaps a consultant will say, okay, well, that chap can go home tomorrow. And yet nobody has seen this patient apart from the nurse, all the nurses who are well aware that that man's not actually moved out of his chair for 3 days. So it's introducing about MDT approach. So we bring nurses, we bring pharmacists and therapists into that scenario. So this has a huge impact for appreciation of roles and how you can work together for the patient. This is a scenario where the patient's been on treatment for pneumonia, clearly has a penicillin allergy that's documented in the medical admission pro forma, and she's sitting there itching. And he spends about 10 minutes chatting to her, not noticing. And then one of the other persons says, "Are you itching?" And then he goes into this long spiel about, oh, she's been given, oh, you've been given the wrong antibiotics, and the patient gets more and more aggravated. And in this 10-minute dialogue, I noted these things were said. Give me a minute. We're only human, after all. We're very busy, so these things do happen. Oh, someone must have forgotten. And although that was interspersed into a more 10 minutes of dialogue, these are the things for me that I think that patient would take away from that. So what do you think will happen as a result? There'll be a huge complaint, won't there? And then as a clinical lead, I have to say to that, and they'll probably say, oh, I don't remember saying any of that. I don't remember saying any of that. So the use of language around a patient, for me, is really incredibly important. So when we first started doing the training, we just did the training with our cohort of medical students who were already in year 5, and we did it with our 30, we get 30 F1s each year. Less than 20% have had any training in ward rounds. All of them thought it was useful. They all rated the quality of the session as really very good, and they all wanted further training. They wanted this to be an onward process as they became more senior. So the lessons and the focus of the scenarios at year 1, you could deliver this to consultants. I have been asked to. Strangely, I haven't had much buy-in from my colleagues, only the ones that are reasonably happy. But this is it, this arrogance that we think that we do these things well, and it's only when you can demonstrate to people that they're not doing it well that you can impact change. I'm sorry this has come out really small. What we always do with each of the trainings is we look at the participants' confidence in leading and documenting, because we also know that translation of what's happened in the clinical interaction does not get written in the notes properly, does it? And then when you're answering a complaint, you look at what's written in the notes. It wouldn't have had any reflection of what was said to that patient about the mistake that had been made with her antibiotics. But we've demonstrated statistically significant improvements in confidence both in leading and documenting ward round. So after this, we presented it at the BSMS, and we've introduced it into the Year 5 programme in the Practice Week. We presented it at the Acute Medicine Conference and the Medical Leaders Conference, and so Bruce Keogh was in the audience there. And we put in a bid for some money to try and help spread the message, because it's so easy to run. So we were lucky and got some funding that helped us to employ our actors. We have this, the name, the Quality Ward Round Programme, which has been set up in KSS. So in 2014, we tried it at another site to see, is it validated, can you use it elsewhere? So we did it at our site for the new F1s, and we did it at Chichester. And we introduced pre-registration pharmacists and some of our Band 6 nurses into it to really demonstrate this role awareness and how nurses and pharmacists, particularly for us, could be fantastic participants in ward rounds. And again, 76% had no training in their core duty every day. And again, we had really good ratings. People felt that this should be part of their undergraduate training, and that included for the pharmacists and for the nurses. And again, we showed significant improvements in leading and documenting the ward rounds. You can see, basically, you won't see the numbers, but you can see it, whoops, cool. You can see a shift, can't you, in the graphs from left to right in terms of confidence. And although you can't demonstrate that confidence translates into a change in practice, you hope that it's going to be contributing, at least raising those thoughts. Looking at our pharmacists and nurses, they also felt that their confidence in playing an active role was improved from having this training. And they also felt clearly that this kind of training would help value their role and what they could play for the patient in that process. So since then, we've sent the scenario packs out to different trusts across Surrey and Sussex, and I'm pleased to say it has been introduced at several sites, but you need people like yourselves to take this away and use it, and you're very welcome to any of the resources that we have. We've used it for induction of all the F1s at SASH, so that's over 160 foundation doctors, and we hope that peer-to-peer observation is really useful. And a friend of mine, Gordon Corbell, who's the legend of the ward rounds, and he was my consultant as a registrar, I went on his ward round about 3 weeks ago as a consultant peer reviewer, and it's fascinating watching how different processes work and the strengths and weaknesses that you can point out just in each other's practice. We've trained over 200 medical students, we're training senior nurses, and we've also trained all the physician associate students across Surrey and Sussex, because I'm also the head of school for the PAs. And we also have an e-learning module, which I'll mention in a minute. Consistently, we've had fantastic feedback across the MDT. This is some of the the free text feedback, really excellent, wish we had more surgeons like it. And for me, this is the most important. This should be rolled out in year 3 and 4 at medical school. It should be before they hit the wards. If you have medical students that aren't sat at the back staring at the wall during a ward round, hoping to learn by osmosis, and you have an active participant, surely their placements and education will be so much more useful and fruitful for them. So this is our e-learning module. It's on the e-learning for health platform. Anybody can register for it. And it's more for a consolidation phase after you've done the simulation training, but it can be used in its own right. It's funny to see some of these are my trainings that were in 2012. Like he's a consultant now in the cardiology reg. It's wonderful to see. I'll look back anyway. It's got modules, an introduction into the quality ward rounds and the key quality standards that you might want to look at for ward rounds. It also plays some scenarios and has a self-assessment quiz at the end, and there's some summary and useful information links. And we're also, hopefully in the next year, going to develop the train the trainer module to go alongside this. Thank you very much.